Hello, everybody, and welcome to this roundtable discussion with the Lobular Breast Cancer Alliance and co-hosted with Share Cancer Support. Lobular Breast Cancer Alliance and Share are partnering on educational programs this year, and also Share is hosting a national helpline where we're partnering together to offer lobular peer support. So we just want to thank Share for partnering and hosting this collaboration for this roundtable, and also thanks to everyone who is joining us today. My name is Leigh Pate, and I'm a coordinator for the Lobular Breast Cancer Alliance. And joining me here today is Elizabeth Viggiano. And Elizabeth will pop on and introduce herself in a minute. And we wanted to say we were really pleasantly surprised and thrilled that we've had 150 people who registered today to join this roundtable discussion. And what we have done is we've had to change the format a little bit. So what Elizabeth and I are going to do is start off this program by offering basically a kind of an overview of what lobular breast cancer is. We didn't want to assume that everyone knew what lobular was and how it was different and why we as patients should care about that. And so we're going to offer an overview of that and then go in. We get a lot of questions about patient advocacy and what is patient advocacy and what can people do. So we're going to go in and kind of give a good overview of that. And we're hoping that should, at the end of that, what we want to do is just sort of open it up for questions. You as participants are going to be muted on this call, but there is a panel and you should be able to type in your questions as we go, and then at the end, and then we're going to try to to answer as many questions as we can at the end of, after the presentation. So I guess we want to start off by, there we go. So first of all, I just wanted to introduce everyone who doesn't know about what the Lobular Breast Cancer is. Lobular Breast Cancer Alliance is, and we're a patient-driven organization. We're patient-led, and we collaborate with clinicians, researchers, and breast cancer organizations, and our goal is to advance lobular breast cancer research and to educate about lobular breast cancer. And we got started as a group basically as patient advocates who came to the very first lobular breast cancer symposium in Pittsburgh in the fall of 2016. There were 30 advocates, and we came in from all over the country, and we were all just thrilled that there was finally something for us for lobular breast cancer. And we met together as a group as advocates, and then slowly out of that, we came away from the meeting and we're like, we really need to write a letter. We need to do something. People need to know lobular is a different disease, and patients need, we need some changes in care, and we need some more research. And so we walked away from that thinking we're going to write a letter. and out of that, over the course of this next year and a half, Lobular Breast Cancer Alliance has grown into a website, and we have an email list, and we have collaborations with researchers and an amazing scientific advisory board. And we're at the point now where we're ready to launch and move forward and really continue the work to advance research and educate about lobular breast cancer. My name is Leigh. I'm the coordinator of it. My lobular diagnosis was in 2011 as early stage lobular breast cancer. I was stage 2B and went through the full round of treatment, and then I have a whole different cancer right now. Some of you have probably seen me with the headscarf on and such, and that is due to treatment to a whole second cancer. So, but I just wanted to, I think there was some confusion about that, but I do, we do want to go through and start now with a little bit of information about what lobular breast cancer is and how it's different. So Elizabeth?
All right, I want to say welcome to everybody who's out there joining us to learn a little bit more about lobular breast cancer. I am a stage 4 patient. I was diagnosed de novo stage 4, meaning my first breast cancer diagnosis was in the metastatic state. It was quite a shock. I had annual mammograms for the previous 12 years. I was diagnosed at age 52, and starting at age 40, I had annual mammograms and they were always clear. So I started to have some unusual neuromuscular symptoms, actually, that took about 1.5 years of an incredible workup. My docs really took me seriously and worked really hard to try to figure out what was going on. And it ended up being sort of a paraneoplastic syndrome that was associated with breast cancer. That was only identified after a bone marrow biopsy to look for something completely different, actually. And on that very day that I had a bone marrow biopsy that I said I had lobular breast cancer in my bone and bone marrow, I had a mammogram. And that mammogram and that breast MRI was clear. And as we talk a little more today, we'll see that my story is not terribly uncommon. I bet there's a couple of you out there who had difficulty in getting your lobular breast cancer to show up on some kind of imaging. So just in a general sort of population context, most breast cancers that we hear about are of ductal histology. Sometimes you'll see it of identified as no special type. That means ductal, and that's about 80 to 85%. The remaining 10 to 12, 14%, the numbers change, is more commonly than lobular. It's the second most common breast cancer and the #1 histologic, distinctly different subtype from ductal. And then there's inflammatory and Paget's and other things that make up the final couple of percents. There's about 40,000, almost 40,000 cases per year in the United States, stage 1 through stage 4. And when we look at cancer diagnosed in women in the United States, if you looked at lobular breast cancer by itself as a unique entity, it would be the 6th most frequently diagnosed cancer in women. So it's not really that rare. In terms of breast cancer, it's not common, but in terms of cancer in women, it's really not as rare as some of our clinicians and the research out there in general could make us feel. There is due to a number of reasons that are supposed or are proposed and not really elucidated yet, of late recurrence and very late recurrence, so greater than 10 years after an early stage diagnosis, and even after 20 years. It's more common for those very late recurrences to often be lobular as opposed to ductal in subtype. And then ILC as a subtype itself has different subtypes. There's the classic, which is the most common, and then there's tubular or pleomorphic or a number of other different types of subtypes that lead to slightly subtle distinctions in terms of maybe slightly different features of aggressiveness or slightly different tendencies for where it may metastasize. But again, we need a whole lot more research to really look at that before we can make gross generalizations around that. So, all of those little bits and pieces taken together form a really pretty robust body of evidence supporting that ILC is really a distinctly different type of breast cancer. It is breast cancer, and just because it is different from ductal doesn't mean it shares no commonalities. But there are some distinctions, and I think with the advent of having genomic and genetic research advancing at the rate that it is, and different types of targeted therapies that are being looked at, we can advocate for lobular specific subgroup analyses, and we might be able to elucidate some of the ways that ILC really is different, and if that difference translates into a different type of responsiveness to treatments. Okay. So as I alluded to, it's not, I don't want to say that it is frequently not detected on mammogram, but for patients who have lobular breast cancer, the majority of those patients do have their lobular breast lesions show up on mammography. But when you look at the subgroup of people across all cancer types, whose breast cancer types, whose breast cancer does not show up on mammogram, it is more common for that to be the story for women who have lobular breast cancer than for ductal. We also know that lobular is very often highly ER positive. It's very less common for it to be triple negative than compared to ductal or even inflammatory breast cancer. And we don't know if it's related to the fact that there are distinct genomic alterations. So as the breast cancer develops, mutations occur. This is different from an inherited mutation. It's a somatic mutation. But there are common mutations that show up far more frequently in lobular than in ductal. And then the flip is true. There are genomic alterations that do show up in ductal more often than it does in lobular. But the more commonly seen genomic alterations in lobular would be primarily a CDH1 mutation. Some researchers and clinicians consider that one of the hallmarks of lobular breast cancer is to have a CDH1 mutation that would lead to a loss of a protein called E-cadherin. And I'll talk about that in just a second. Other common genomic alterations are also PI3K, which is really sweet for us that have lobular because Pelicib, a new PI3K inhibitor, is on the market. And so there may be some subgroup analysis in the future to see if lobular may be more responsive or not. And then FOXA1 and TBX3 have also been found in a number of genomic tissue analyses, but as of yet, there's no real understanding of how that plays into lobular progression or development, or even if those are targetable mutations or not. Okay, thanks, Leigh. So I talked about CDH1 and the loss of this, this protein called E-cadherin. And E-cadherin plays a number of roles in cells, but the primary one that's of interest to us is that it tends to make cells sticky. And the loss of that seems to facilitate lobular breast cancer cells being able to spread and metastasize in a different way than ductal cells do. So this is one of the reasons why it tends to not show up very well in mammograms or MRIs or later on in the metastatic state in CT scans or even PET scans. Because if you look at the image on the left there, those blue, the dark blue cells are the lobular breast cancer cells, and they tend to form single file lines, which then can form either nets or webs or sheets that overlay on each other, as compared to the center image, which is ductal cells, which sort of all clump together in more of the typical mass or tumor that we tend to think of cancer being. And then the image on the right shows a little bit with ILCs, because some people have mixed IDC and ILC. And so the single file lines are the ILC component, and the more clumping, clustery would be the IDC component. So I just thought it might be helpful for people to sort of have a visual in to imagine or to see how these tumors are different. So if it doesn't form lumps, how does lobular breast cancer tend to present itself in the body? So I think this is really important for us as friends of other women, as mothers, as sisters, as colleagues, to let people know that it's not always the lump that you're looking for. There's that the tissue can just feel hard, or an area of roughness under the skin when your fingers are palpating your breasts. One breast can become really more asymmetrical than the other. I mean, it's really common for women to have asymmetrical breasts, so I don't want people to think just because one breast is larger than the other, the larger one has cancer in it. But if you change from your normal asymmetry to more distinct asymmetry, that could be a warning sign. Dimpling or any kind of nipple changes or discharges, or it seems like your nipple moves in position on your breast, or sometimes a pain in your breast. Any of those could be signs of breast cancer. They could also be signs of things that are not breast cancer. And you can also have ILC and not have any of these symptoms. So again, just be aware. Breast cancer is tricky. So like we talked about, especially if you have dense breast tissue is very difficult for radiologists to read, whether you have ILC or IDC or anything else. The density of the tissue can make it difficult to decide if something is truly suspicious or not. But it tends to be more difficult to see ILC, probably because the radiologists suspect that it's due to that single file, thin sheet nature, tends to look and sort of camouflage itself among the normal breast tissue, and it's not as easy to pick up on a mammogram as a distinct, something that would be more dense in appearance on the image that they're looking at. So the left is just normal breast tissue that's dense, so that fibrous consolidation in there is all completely normal. And then there's dense breast tissue with a tiny little component of ILC. So it's tricky. I can get why it could be missed. And then when we think about trying to image metastatic lobular disease, knowing that just like in the breast, it forms thin sheets or small little single file colonies. When you're looking at other organs in the body, it's not as distinct there as well. So here we have an abdomen, a cross section through an abdomen where the arrows up top are pointing at little masses. That is ILC. But the dark tissue, the dark spots in there is actually air in the bowel. So it's the tiny little gray areas that are the peritoneal metastases interspersed there, probably on the lining of the colon or on the surface of the colon, kind of obscured by the air that shows up as black. So again, it's tricky. PET scans, a lot of times people will say, well, why don't we get a PET scan? And lobular breast cancer is not only genomically different and structurally different, it appears to be metabolically different in that the imaging agent called FDG, it's a type of glucose that's been tagged with a radioactive tracer, and tends to be uptaken more in ductal cells that are very metabolically active. It doesn't tend to be as uptaken in lobular cells. So the lobular cells being not as dense and more diffuse and less likely to take up the imaging agent makes PET scans not always the best imaging modality to try to find a lobular metastasis. Depending on where you're looking, CT scans or MRIs can sometimes be more sensitive. to lobular. So I'll have a lot of times patients ask me, why I don't ask my provider for a PET, and it's because I've had one, it didn't show anything, and there's really good metabolic reasons for why that's the case. The other thing that's really interesting about lobular breast cancer is it has a typically different metastatic pattern when compared to patients with ductal. When you think of ductal breast cancer, it's very common for it to go to the bone, the brain, the lung, and the liver. Those are really the ductal's foremost common places to go. And lobular breast cancer seems to be very happy in the bone. Many patients with lobular breast cancer metastases have bone metastases, but it is less likely to go to brain, lung, and liver compared to ductal, and far more likely than ductal to go to unusual places in the abdomen, the ovaries, the peritoneum, the omentum, inside or outside the colon, inside or outside the bladder, sometimes even in the eye or the orbital socket around the eye itself. So it's important, if you have lobular breast cancer, either early stage or metastatic, to be aware of the differences. If you go to an oncologist who may not be a breast cancer specialist, or even a breast cancer specialist who may not have had experience with a lot of metastatic lobular patients, they may not have encountered in their experience very many patients with abdominal, GI, colon, bladder metastases. So self-advocacy is really important for you to say, something doesn't feel right. I need you to really hear me. And, in the lens of the fact that I know that lobular does have a tendency to metastasize differently than ductal, can we work together to try to figure out what's going on? So these are just some pictures of what metastases might look like. So on the left are tiny little white dots there. This is the inside of a colon from a colonoscopy. Multiple little teeny tiny, those lesions are 1 millimeter or less. Oftentimes, if you have what's called a colon polyp, that they're more commonly looking for when you have a colonoscopy, they're in the many millimeter, 5, 6, 7, 8 to 1 or 2 centimeters. So they can be 2 to 20 times bigger than those little lesions that are inside the colon. The next one are a couple of tiny little lesions scattered on the outside of the colon. This is a massive, I don't know if you can see on the top and to the left side of the third picture are gloved fingers pulling away part of where the colon is resting on the peritoneum, which is the back lining of the abdomen, and all those little white dots are tiny little metastatic lesions. And then in the last one is pictures of pleural met, so pleural meaning lung. So there are tiny little metastases, the little bits of gray fuzz scattered throughout the lung there, which is different if you had ever looked at lung cancer or ductal breast cancer spread to the lung. There's usually, something maybe like the size of a nickel or a dime or a quarter, a really dense white lesion that shows up. So on imaging, lobular metastases are very different and very difficult to see. Sometimes direct imaging like this, getting in and doing a colonoscopy or a laparoscopy to somehow get an actual look, will show things that scans don't show. Right, and there are a number of really good articles, and many of them are archived on the Lobular Breast Cancer Alliance's website that talk about imaging and the differences that could be used, the different modalities that could be used to help you look at potential metastatic spread.
Thanks. Thank you, Elizabeth. So we wanted to touch briefly on advocacy because we get a lot of questions about that, and the goals of LBCA's goals for advocacy are are twofold. One, and first and foremost, is we really strongly want our advocacy to meaningfully advance lobular breast cancer research and clinical application to help refine treatment for patients and improve outcomes for patients. And to do that and to help patients navigate this disease better for themselves, is we want to educate and also raise awareness of lobular breast cancer. So these are our goals: to advance research and to educate and raise awareness, because we need more focus on lobular breast cancer within the breast cancer research and the larger breast cancer community. So there are many attributes to a great advocate, and the main reason for showing you this is to convey two things. First, you do not have to be a scientist or a healthcare professional to be a good advocate. There are many, many ways to contribute and get involved, or just be your own personal spokesperson in your own world for lobular to help others. But one thing I did want to point out that the best advocates really have the ability to represent all patients and not just your own story. And so we highlight this because sometimes as you're going through your treatment and then all the shock and trying to navigate life after treatment, we're all very focused on, oh my gosh, it's time for radiation. How much radiation should I get for lobular, and what does that look like, and how do I get that information? And sometimes it takes a little bit of time just to step back, let things process, and then decide, how is it, I really want to do something to help make this better for future patients and for people coming along and help to try to end this disease, and to be able to step back and figure out, how do I do this in a way that is beneficial to everyone? So sometimes we often recommend that for folks who are interested in advocacy, sometimes it's helpful to take a little break between your treatment and starting on advocacy, just to let the world settle out a little bit for you to have your own perspective on what it is you want to contribute and accomplish. So there's advocacy defined broadly, or research advocate, which is a more specific type of advocacy. And so very briefly, Webster's and the NCI definition of an advocate: advocates don't have to be patients. They can be, one of our strongest advocates in LBCA is actually the mother of a patient. It can be a caretaker or a patient, who are all really interested in contributing their skills and perspective to improve the lives of others with this disease. And there are many ways to become an advocate. One is to educate others, and this includes healthcare providers, raising awareness and actually trying to introduce others to what lobular breast cancer is and how it's different, and the fact that we need more research. Fundraising to help support research grants or the organizations that provide services or advocacy. There's advocacy can also be helping to support other patients. SHARE is a fantastic organization for that, and a partner that has embraced and included their support services that are addressing the needs of lobular cancer patients specifically. And so for example, one way to become an advocate, if peer support is of interest, is to reach out to SHARE and see what their programs are about as a potential way to become an advocate. And then there's policy advocacy, which is a different, this is a way of actually going to, say, Capitol Hill or the state legislature and working on policy initiatives for things like increasing government funding for breast cancer research, or there's a bill right now that would for metastatic breast cancer patients so that there's no waiting period to qualify for Medicare or SSDI. And there are organizations, not LBCA, that that have entire policy advocacy shops and work on Capitol Hill and lobby. The National Breast Cancer Coalition is one. Komen has a policy shop, and so there are different ways to get involved in that way. So there are many ways to become an advocate, and there's all kinds of levels to get involved. Now, a research advocate is a little bit of a different thing, and this is something that LBCA focuses on a bit more, because we believe this is a very important way, this is a very important part of advancing research that includes lobular breast cancer, and to get more funding and more research going for lobular breast cancer. So a research advocate is actually a patient or a caregiver or someone with an interest in lobular breast cancer who can actually serve as a link between patients and scientific researchers. They can work directly with researchers and people running clinical trials to make sure that the patient perspectives are integrated into the decisions that are being made for setting up trial studies or protocols, or you know, and that the priorities of things that are clinically relevant for patients are integrated into the choices for research. So, for example, you know, keeping research. There are many interesting questions that can be researched and that scientists might find interesting. But one of the main jobs of a patient advocate is to say, hey, you know, let's focus our research priorities on things that are going to be clinically meaningful and make the lives of cancer patients better. You know, or taking a look at a study protocol and saying, gosh, you know, do we really need 3 biopsies for this research? And so forming those sorts of collaborations and helping to make sure that research is successful, that the trials get filled, and the research is successfully completed is a very important role that a research advocate can do within breast cancer research. Um, Now, research advocacy, some people find it, this is actually a role where if you're a scientist or have a good science background, or if you're a have a healthcare background, that can be helpful, but it's not necessary. I mean, me personally, I had biology in 9th grade, and that was about the extent of my science training. And when I became interested in becoming an advocate, I took advantage of some really excellent learning opportunities. One is called Project LEAD, that is sponsored by the National Breast Cancer Coalition, which is basically extensive remedial science training for people like me who need to get a good base of science so we can contribute meaningfully as a research advocate. Some of the things that research advocates can do are you can partner with on grant applications and to partner with scientists as they're submitting for money to fund clinical trials or studies, to help, first of all, review the protocol that's being submitted and offer suggestions on the lay language of that, and then lend letters of support to support that grant application. Patients can do grant review, where you actually sit on and actually review requests for funding that come in, and and basically make decisions on what sorts of studies get funded. Some cancer institutions have patient advocate committees locally at the cancer institution, and so you can get involved in those opportunities. And then there's, you know, much of the work of science and medicine And the collaboration happens at these big conferences, the San Antonio Breast Cancer Symposium, the American Association of Clinical Oncology, the ASCO, which is the big, all the cancer docs have their big meeting, and this is where research is presented and reviewed and discussed. And it's very important. Patient research advocates um, need to be present at those meetings to represent Lobular there, because that's where everybody goes to collaborate and talk. So it's important to be represented as a patient there with lobular breast cancer. So this is a big emphasis area for LBCA. So there are many things that you can do to be an advocate, um, and they involve, and some of them are very simple things that can be done every day, um, or in the course of your own treatment. First of all, is try to communicate with your medical team and your networks and the organizations you're in about lobular breast cancer and what it is. I mean, just being a spokesperson in your own world. And then communicating with your own medical team is very important for self-advocacy, as many of us have discovered. And but also the benefit of communicating with your medical team about lobular breast cancer, and asking your questions of them, is that it makes them focus on lobular, and it may improve maybe the communications going forward of how they interact with future patients with lobular. And we hope that they're going to say, gosh, I'm getting all these questions about lobular breast cancer, and they start asking and demanding better answers from those that are conducting the clinical trials, and wanting to have better solutions for their patients and their interests. So please speak up with your own medical networks. Educating yourself and others about ILC can be as simple as, instead of saying I have breast cancer, say I have lobular breast cancer. And there you've just immediately opened the door, because I can guarantee you 95% of people have never heard of it, and they're going to say, you have what? And then you have the opportunity to explain what it is and to educate them about the disease and how to recognize it for themselves. Um, and then there are other opportunities and ways to educate others, including you can maybe ask for at your local support group. You can work at your local institution and ask for an educational presentation. I mean, there are many different ways. We'll send you brochures. You can print out materials at the website and share them with your local affiliate organizations. There's lots of ways to try to help spread the word and educate others, and we're happy to support that if you want to send us an email. Participating in research right now, for example, if you have metastatic breast cancer, you can participate in the Metastatic Breast Cancer Project. There's information about that on our website. But when lobular breast cancer is only 10 to 15% of all breast cancers, then it's very important, when there are research opportunities to study the disease, that patients, if it's right for them and the right choice with them and their care, to participate and try to fill those studies, so that we learn as much as we can about the disease as we have the opportunities to do so. Of course, fundraising and supporting the organizations that are providing support. Because sadly, money makes the world go round in these sorts of endeavors. And then you can learn more. We have a whole section we have a advocacy toolkit, and you can go online, and we have resource lists, and we have other suggestions for how you can get involved in advocacy, and including research advocacy, and a whole resource list that you can download that has training opportunities. If you're interested in research advocacy specifically, please send us an email, info@lobularbreastcancer.org, and introduce yourself. So just to wrap it up, lobular breast cancer has distinct differences as a disease. And many of these differences are becoming more and more apparent as more research is going on, and they've sequenced it and understand some of these molecular differences. We need clinical trials to refine treatments for patients, and ultimately to get treatment guidelines refined and changed, because the treatment guidelines will not change without the clinical trials that support that research. We also are very excited and really want to make sure that we have research to understand the biology of the disease and potential targeted therapies. This is the, you've heard the term precision medicine. This is precision medicine, and we don't want to be left behind. And there are some differences in the disease that are being studied in the lab that could be quite promising to move forward into therapies for treatment in the clinic. And we want to do everything we can to support moving those things forward. We have learned that patient involvement is critical to advancing research in lobular. They knew what lobular was decades ago, and for years lobular was has been treated the same as ductal breast cancers. And we've seen a lot of change and a lot of energy quickly just in the years since the first annual symposium and the LBCA has gotten started. There's been a lot of momentum in energy, and we think a lot of it is because patients are speaking up and saying, hey, this is important, actually, we really want some attention, and going forward to try to form these collaborations to get integrated in breast cancer world. So the patient voice is incredibly important. We believe education and outreach and all of the awareness building is important to build the momentum to create the energy to do more research. So not only does it help patients get better care, not only does it help patients advocate for themselves and get information that we need about our disease, but it also will catalyze interest in research, which is what's going to change some of the treatment guidelines that we're all interested in. And then, of course, the funding and the advocacy for funding for the research. So if you go to lobularbreastcancer.org, there is a lot more information about ways to advocate. And anyone who's interested in advocacy, please reach out to us, and we would love to talk with you about that. So, and Elizabeth, did you have anything else that you wanted to add to that?
I think something, you know me, Leigh, this is one of my personal challenges as a metastatic lobular patient, that in order for lobular breast cancer patients to be included in clinical trials, oftentimes, due to all of the difficulties with imaging, we don't meet the eligibility criteria because there are very specific ways to measure the presence and the response of our lobular tumors, or of breast tumors or breast cancer tumors, to the treatment. And because of the challenges with imaging metastatic lobular disease, oftentimes we don't meet the requirement to even get into the trial. So very pointedly, I think what some of the research is that needs to happen is other ways to find, to see, to quantify, to measure. I'm thinking like liquid biopsies, measuring cell-free percentage of CDH1 in response to treatment. Does it stay the same? Does the percentage of that mutant DNA that's circulating in our blood go down on treatment? That could be a good thing. And right now, there really is not even that early state preclinical research happening. So we do need ILC patients to help advocate, at the industry level for something different for us, so that we can get into clinical trials, so that ultimately we can see if there are treatments that are beneficial for us or not. Yeah. It's frustrating. Yeah.
So, and Christine, I don't know if you're still on, but I am not seeing any questions, which I find it hard to believe.
I have questions. Christine sent some to me actually by text as they were coming in. So I don't know, maybe you have my same, you can't see them.
No, I can't see questions. Yeah.
We've had difficulty with this part. So there was a question early on about, about pleomorphic lobular. And the specific question was to address the latest work on pleomorphic cells. And I am not in a position to address the most recent work because I'm frankly not aware of the most recent recent, but I follow it pretty closely because I do have pleomorphic lobular breast cancer. In general, pleomorphic means it's a way to describe the histology, the appearance of those cells under a microscope. So whereas in general, most cancer cells look very much like each other, and they look very much like a typical cell in terms of their size, their shape, their cell wall, the nucleus, the organelles that are inside the cell. Pleomorphic cells are different. Pleo means many, morph means shape. So they have many different shapes. They are often, but not always, patients with pleomorphic cancers of many types. It's not a term that's reserved only for lobular breast cancer, but patients with pleomorphism in their cancer cells tend to have more genetic mutations. It can sometimes confer a more aggressive nature to your cancer. It can sometimes confer a better response to chemotherapy than typical lobular and lobular specific, because it is a little different from basic. So I don't really know anything more to say about the current thinking about what role pleomorphism plays in thinking about how to approach lobular breast cancer in particular, but it's a small percentage of lobular patients who have pleomorphic cells. So when you think about a small percentage of a small percentage, pleomorphic lobular breast cancer cells are probably, in the single-digit % of all breast cancer. It's going to be very hard, I think, to get attention or sufficient data to come up with really strong conclusions about what pleomorphism means for lobular breast cancer patients. So there's a couple of, Leigh, can you not see anything?
I see nothing.
Okay.
Sorry.
So there was a question here about what de novo means. De novo means from the start. So as somebody who's diagnosed de novo stage 4, that's typically when you see that word, means that you're metastatic at the very first diagnosis. It has some implications in that the SEER database that follows patients who have breast cancer and who ultimately die from breast cancer only count the stage 4 patients who are de novo stage 4 at this point in time. There's some push to have that change. So some of the numbers representing breast cancer across the board, not lobular in general, but not lobular in particular, whether you have that de novo or not, it may influence statistics in the end. There's also a little bit of evidence that patients who are diagnosed de novo stage 4 from the point of their diagnosis tend to have a slightly longer overall survival interval. And I do know, talking to some researchers, that they believe it's because our breast cancer cells at that point in time have never been exposed to any of the adjuvant or neoadjuvant chemo or the time on tamoxifen or previous aromatase inhibitor exposure. So our cells are novel to those and get a little longer time on a lot of those treatments because they've never had to learn how to trick their way around them. So there's a couple of months of overall survival benefit. In general, as a population, when you look at people who are de novo stage 4 versus the people who progress to stage 4 after an earlier diagnosis. So there is some difference that holds up across the decades for de novo patients diagnosed de novo. Sorry, I'm trying to read and also answer questions. Let's see. So I don't know. Leigh, do you know anything? Somebody asked, what's the rate of recurrence for ILC after early stage?
I don't think that it's ever, to my knowledge, it's never been looked at specifically for ILC, rate of recurrence. is thought in general to be up to 30% for all breast cancer.
Right. I haven't seen anything distinguishing a different recurrence rate for ILC compared to ductal also. Somebody asked about what the role of tumor markers have for monitoring ILC metastasis to the bone. So tumor marker is a term that is really broad. There are a variety of tumor markers. I think people tend to think of either CA15-3 or CA27-29 when they say, you know, does your doc order tumor markers for you or not? But for me in particular, I know my oncologist, for my very extensive bone metastases, looks a little bit at the CA27-29 marker and a whole lot more at my alkaline phosphatase. That's an enzyme that's released from bone when bone is either injured or repairing itself. So that's a potential marker. It tends to rise only after relatively extensive bone metastases, so it's certainly not a diagnostic tool. If the person who asked that question is an earlier stage patient or a person with with limited bone metastases, you may have a normal ALK phos level, and then that would not be very useful in following. Probably scans or something else would actually better detect your metastatic progression in your bone than an ALK phos level. Just really quickly, because people tend to ask me this a lot, even though it wasn't a specific question, but I'm going to tag on to that tumor marker. The reason some oncologists don't follow tumor markers is both the CA15-3 and the 27-29 look for a portion of a particular protein that's on the surface of breast cells. So as the breast cell becomes cancerous, sometimes that protein will be conserved, and so it's still present on the cancerous cells, and sometimes it gets lost. So some people can have a lot of cancer, but if as their breast cell became mutated into a cancer cell, it may have mutated in a way that they lose that protein marker on the surface of the cell. So you can't check for its presence in the bloodstream. If people have that protein, it's MUC1, MUC-1, and the only reason I say that is there are a couple of clinical trials coming out that are sort of targeting that MUC1 protein. So the 15-3 and the 27-29 look at different parts of that MUC1 protein. And if your cancer, your breast cancer cell has kept the MUC1, that could be a good way of following increase in or response to treatment as the levels change. There are other things, inflammation, infection. Other cells also have MUC1. So if you have injury to those other cells due to an infection or inflammation somewhere else, you can have an artificial rise. Well, you have a real rise in your tumor marker, but it's not really due to your tumor. So they're tricky to follow. That's the whole point I want to get at in terms of tumor markers, is they can be a point in the picture, but they certainly are not the whole picture. And they may not work for some people at all if their cancer cell doesn't keep that protein. Somebody asked, does anybody know anything about the time it takes to progress from stage 1 to stage 4? And you know what? They don't really know. And there's some evidence. I was at a conference last year where an epidemiologist was talking about metastatic progression and metastatic seeding. And there is increasingly more evidence that that more often than we think, and I don't know what that number is, that there is micrometastatic spread almost at the same time there's cancer development. And that for whatever reason, those little micrometastatic cells that are hiding in oftentimes bone marrow stay dormant forever. So when they do autopsies, people who have had early stage breast cancer 50 years ago, at the time of their death, they have metastasized to their bone or bone marrow, and it's never gone any farther. And so there's a lot of research ongoing right now looking at those metastatic colonies to see what promotes them staying asleep and what prompts them to wake up and get active. But they believe that there is spread equally through the bloodstream or similarly through the bloodstream as through the lymph nodes, and that simply having node negative disease is correlated with a lesser likelihood of future metastasis. But there are people who do develop metastases with node negative disease, and they think it's often because it might be that those metastatic cells have traveled through the bloodstream instead. So I hope I don't scare anybody, but that's the truth.
Elizabeth, yeah. There's about 4 minutes left.
Okay. There are a bazillion other questions. Somebody wanted to know about GI Mets, and I'm just going to say that there are a number of people who have GI metastases and what the symptoms are for that. And there are many of us. I've been metastatic now for a little over 4 years. My abdominal, peritoneal, omental, colon, and ovarian mets were all found during laparoscopic surgery 2 months after my metastatic diagnosis, and I still have no symptoms 4 years later. And then there are other people who have lots of stomach problems. So I think it's hugely variable. So there you go, Leigh. Do you want to do the final wrap up?
Sure. Well, thanks. We want to just thank everybody. Thanks, Cher, again for partnering to host this, and for everyone who joined us. A couple of things that are coming up, just so you know, on September 7th, which is next Saturday, the Northwest Metastatic Breast Cancer Conference is going on here in Seattle. If you are in the Pacific Northwest, you can still register to come join us. Elizabeth, Christine from Cher, and I will all be here, and we would love to meet you. And there are some travel scholarships and some housing scholarships that are available, and so you can go to our website and follow that link and get more information about that. You can also register for the live stream if you want to watch it, the entire conference live, and we will actually eventually we'll get the recording of that, or the whole day, and we'll have that on the LBCA website as well. And then on November 13th, Cher and LBCA are going to be co-hosting another webinar. Is going to feature 2 of the physicians on the LBCA Scientific Advisory Board, and we're going to be talking about metastasis. And this is open to everybody who is interested in kind of what lobular metastasis is and how it works. That's going to be 1 p.m. Eastern time on November 13th. And I think that we have 1 minute, but again, just thank you again to everybody for joining us today, and thanks to Cher for hosting.
Leigh and Elizabeth, this is Christine. Can I just interject something real quick? Someone asked on the questions what the current clinical trials are for lobular breast cancer, and I wanted to let people know about the Metastatic Breast Cancer Alliance. It's an alliance of 30 breast cancer organizations plus industry, and the alliance has created an app called MBC Connect, where metastatic patients, go in, enter their information. It's a registry. Researchers will be able to use de-identified information in their research. But in beta testing right now, that app is going to be able to match patients. So the information that you put in will match you with clinical trials that you might be eligible for. So you could check that out on the mbcalliance.org website, or just Google MBC Connect, and you'll find information about that app there.
Yeah.
Great.
Okay. Well, thank you, everybody. And thanks to Cher for co-hosting this event.
Thanks, Leigh. Thanks,
Okay.
Elizabeth.
Thank you, guys. Thank you, Cher.
Thanks for participating. Bye.
Bye-bye.
Bye-bye.